Hello, my name is Piyasha Saji Patharapong. I am an emergency physician at Khon Hospital, Thailand. I have completed an emergency ultrasound fellowship from University of Southern California. Today, I will be talking about POCUS in pulmonary embolism and aortic dissection, the essentials. So let's get started. I have no conflict of interest to declare. First, we will talk about the diagnostic approach for PE and aortic dissection and role of POCUS in the acute setting, and size of POCUS and their accuracy. So we'll start with pulmonary embolism or PE. PE is when a thrombus becomes large in pulmonary arteries and blocks blood flow to the lung. It's a life-threatening condition that requires immediate diagnosis and treatment. PE has a high morbidity and mortality and require aggressive therapy. Symptoms and signs can be nonspecific and atypical, often being elusive, and therefore unrecognized in time. Of all PE-related deaths, 59% were undiagnosed and untreated, and 34% were sudden fatal PE, who died suddenly or within a few hours of the acute event, before therapy could be initiated or take effect, and only 7% of patients who died early were correctly diagnosed with PE before death. How POCUS can help in PE? Briefly, POCUS can be used for establishing the diagnosis, especially in patients with shock or cardiac arrest where CT scan is not feasible. POCUS can be the only bedside test we can use. POCUS can also help with differential diagnosis, identification of high-risk PE patients, for making therapeutic decisions and monitoring the effect of therapy. According to ESC guideline, in suspected high-risk PE with hemodynamic instability, bedside echocardiography and CTPA are recommended for diagnosis in hemodynamic instability patients with suspected acute PE. If there is no echo sign of right ventricular dysfunction, search for other causes of hemodynamic instability. However, if the sign of RV dysfunction listed here are present, then proceed to therapy if CTPA is not immediately available or feasible. The sign of RV dysfunction refers mainly to an RV to LV diameter ratio more than 1, hypokinesis, McConnell sign, 60-60 sign, and TAPSE less than 16 millimeters. In cases in which the patient's condition is so critical that it only allows bedside diagnostic tests, echo findings of RV dysfunction confirm high-risk PE, and emergency reperfusion therapy is recommended. As soon as the patient is stabilized using supportive treatment, final confirmation of the diagnosis by CT should be sought. In suspected PE, it may be better to use multi-organ ultrasound, which is a combination of cardiac, venous, and lung ultrasound. We'll start with cardiac ultrasound. So the first side is RV dilation from apical for chamber view. RV to LV ratio greater than 1 can be noticed. From a study in 2014, right heart strain is 98% specific for PE and the sensitivity is 50%. It's really not that sensitive. If you don't see it, it could still be subsegmental PE. The right heart enlargement does not rule out PE. It helps you rule in a bad PE. RV dilation of echo is an indirect sign suggestive of intermediate or high-risk acute PE, but could also result from other causes, for example, COPD, pulmonary hypertension, chronic lung disease. However, this may not be useful in cardiac arrest. A study from Denmark in 2017, they took 24 pigs, they put them into cardiac arrest through arrhythmia, hypoxia, and PE. And in all 24 pigs, RV dilated within the third rhythm analysis of cardiac arrest from all causes. So we know from animal models that RV dilation is a common phenomenon in cardiac arrest. It's not specific to PE. So RV dilation after cardiac arrest should not be taken as an exclusive sign of acute PE. Other cardiac PE signs are D-shaped LV and signs that are more specific to PE highlighted in yellow here, which are McConnell sign, 60-60 signs, early systolic notching, RV free wall thickness, and right heart thrombus, and another sign for PE is TAPSE. The second sign In parasternal short axis view, interventricular septal flattening, so-called a D shape of LV, can be seen because of a decrease in LV filling and higher pressure in RV. The first more specific sign to PE is mechanosine or preserved contractility of RV apex as opposed to hypokinetic RV free wall. However, this finding is present in only 12% of unselected PE patients, and subsequent studies have shown that it can occur in other conditions such as an RV infarct or even chronic pulmonary hypertension. So you have to be careful how you use it. Certainly, if you have high pretest probability and you see this, then it's very likely that the patient has acute PE. So-called 60-60 signs can only be detected by continuous wave Doppler, consisting of the first one is mildly elevated peak systolic gradient across the tricuspid valve or TRPG less than 60 mm of mercury, measured by the velocity of tricuspid jet in the absence of previous pulmonary hypertension. The RV is much thinner and lower in muscle mass compared to the LV. Thus, a significantly higher RV systolic pressure can only be generated if there is a slow increase in the RV afterload, allowing for myocardial hypertrophy. If there is a sudden increase in the TRPG over 36 millimeters of mercury but less than 60 millimeters of mercury, this can be more reasonably attributed to an acute insult such as a large acute PE. If TRPG is over 60 millimeters of mercury, it can be theorized there is a chronic process at play allowing for the RV to accommodate such elevated pressures through slow hypertrophy. And the second one for 60-60 sign is short pulmonary ejection acceleration time, less than 60 milliseconds. In the parasternal short axis view, you use a pulse wave Doppler pointing across the pulmonary valve, and you place a sample volume of the pulse wave Doppler just above the pulmonary valve in the RV outflow tract. This measures how quickly it takes for flow out of the RV to reach maximal velocity during a cardiac cycle. We measure the amount of time it takes to start the ventricular systole to its peak, and what you get is the waveform, which looks like in normal individuals slopes up gradually. PAT is shorter when afterload or pulmonary vascular resistance is higher, like in acute PE, since the obstruction is very proximal. Normal PAT is over 130 milliseconds, while a PAT of less than 60 reflects a markedly abnormal acceleration time. This one is 46, so this is an acute process. And early systolic notching is another finding that you can use. You look for the actual morphology of the flow through the RV outflow tract. The spike is a narrow peaked initial wave with early deceleration and had to occur within the first half of systole, followed by a second Doppler wave that is more curvilinear. This is early systolic notching, meaning it's an acute process. The obstruction occurs during the early part of the cardiac cycle. So how is the accuracy of these POCUS signs? A paper from the US in 2019, they looked in patients with massive and submassive PE. They found that early systolic notching seemed to be more accurate than McConnell's and the 60-60 signs. However, this paper, they excluded patients with chronic pulmonary hypertension, and also the scan was performed by relative experts in echo. There's quite a few caveats in this study, and I don't think this should be a routine part of our assessment. It's more just something to mention that may become more widespread in the future. For RV free wall thickness, measured in subcostal long axis view at end diastole, if the RV wall is less than 5 millimeters with RV dilation, it is likely an acute process like acute PE. But if RV free wall thickness is more than 5 millimeters, then it's more of a chronic process. For example, chronic pulmonary hypertension, or it could also be acute PE on top of chronic disease. A direct sign of PE is the presence of right heart thrombi. However, they can be seen rarely in just 1.8% of all patients with PE and increase to 18% of patients with high-risk PE. Mobile right heart thrombi essentially confirm the diagnosis of PE and are also associated with high early mortality, especially in patients with RV dysfunction. And finally, Decrease tricuspid annular plane systolic excursion or TAPSE to less than 16 mm measured by M mode indicates also RV dysfunction. TAPSE also have a role in predicting outcome in PE. A study from Spain in 2014 have found that TAPSE of 16 or less means that the patients are 4.4 times more likely to die from PE. Caution is that a normal cardiac POCUS does not mean no PE. POCUS can only detect PE that cause RV strain. Many patients can have PE that have no RV strain. Only massive and submassive PE tend to have RV strain. Thus, POCUS is specific for PE, but POCUS has a poor sensitivity for PE. You can have a completely normal ultrasound and the patient can have a PE. However, the ones that we worry about in the emergency department are PE that have RV strain that can cause the patients to have cardiac arrest. These ones are generally picked up on ultrasound. Moving on to venous ultrasound. Compression venous ultrasound can really be helpful to perform in patients with suspected PE done at bilateral groins and popliteal sites. Incomplete compressibility of the vein shows 90% sensitivity and 95% specificity for proximal symptomatic DVT. Detection of proximal DVT in a patient with suspected PE virtually confirms the diagnosis and fully justifies anticoagulation. On the left side of the screen, you can see compressible right common femoral vein with both anterior and posterior walls coming together with compression. These are normal veins. But on the right side of the screen, common femoral veins are not fully compressible, and here you can actually see an echogenicity representing clot within the vessels. This is a patient with DVT. Moving on to lung ultrasound. Common findings in lung ultrasound in acute PE is normal lung. However, you can sometimes see wedge infarct, which is a hypoechoic area extend down from the pleural line and generally in between 0.5 and 3 cm in depth. And if deeper than that, it should raise a suspicion of malignancy or a lobar pneumonia. However, you can also see this finding in COVID-19. And it can look similar to wedge infarct that you see in PE. The literature suggests that it's a form of immunothrombosis arising in situ, rather than embolism from a distant DVT source. So how can you tell apart? If the patient has confluent B-line, pleural line irregularity instead of patchy bilateral distribution, this would be a classic COVID pneumonitis. However, COVID patient could have PE as well, so if in doubt, order CTPA. The infarcts in PE are normally present in the posterobasal segments of the lungs, but it can also be present in all lung area. Moving on to multi-organ ultrasound, which is a combination of cardiac, venous, and lung ultrasound. You can see here that the accuracy of a single organ ultrasound, a sensitivity is not high enough to be used at a single test. For single cardiac ultrasound, the sensitivity is only 32%, but for high mortality pathologies like PE, we would like to have a sensitivity of at least 85%. For multi-organ ultrasound, it shows a sensitivity of 90% that was significantly superior to lung, heart, and DVT ultrasound alone, and a specificity of 82% for PE. Next topic is on to POCUS assessment of aortic dissection. Aortic dissection is due to the separation of the layers of the aortic wall. A tear in the intimal layers results in progression of the dissection chiefly due to the entry of blood in between the intima and media. Among acute aortic syndrome frequency, acute aortic dissection type A is the majority of cases. It's very difficult to diagnose. The misdiagnosis rate is around 14 to 16% from the clinical study. Data from the registry show that in the absence of immediate surgical repair, medical management alone is associated with a mortality of nearly 24% by 24 hours after presentation and 49% by 14 days. Aortic dissection detection risk score is a standardized score based on 3 items: high-risk conditions, high-risk pain features, and high-risk examinations features. An ADD risk score of 0 points is low risk, 1 point is moderate risk, and 2 to 3 points is high risk. Following ESC guidelines, For suspected aortic dissection, TTE is recommended as an initial imaging investigation in both stable and unstable patients. In stable patients, we can use ADD risk score and with biomarker like D-dimers that has high sensitivity to rule out aortic dissection. We can consider stable patients not in shock or peri-arrest situation. Patients can be proceeded to get CT scan, but in unstable patients with shock or peri-arrest, POCUS can be the only test that can be done at the bedside to rule in or rule out aortic dissection. Ultrasound view necessary. The first view is parasternal long axis view. It gives us a good view of the aortic valve, the LV outflow, and the aortic root. Vast majority of patients with a little bit of adjustment. We can go a little bit further north and we can see more of the ascending aorta. Occasionally, you might have to bring the patient on a right lateral decubitus position and scan from the right side of the sternum. The next view is suprasternal notch. We can see the aortic arch, and we can see the medial segment and the distal segment of the arch and a little bit of descending aorta. One of the most important indirect signs of aortic dissection is thoracic aorta enlargement to more than 4 cm diameter, measured from leading edge to leading edge at the largest visible portion of the aorta. The direct sign of aortic dissection is intimal flap. You can see the intimal flap within the aortic root separating two aortic lumens from parasternal long axis in this patient. This one is suprasternal view. You can see the intimal flap in the aortic arch and descending aorta in this patient. This one is suprasternal view. You can also see the intimal flap in the descending aorta in this patient. Another view is parasternal short axis view. If you rotate the transducer so that it's parallel to the spine, often you can get a longitudinal cut of the descending aorta. This is a patient with a dissection within the descending aorta. You can see a flap within the lumen. And the last one is abdominal view. This one is the proximal abdominal aorta in sagittal plane. You can also see the flap inside the lumen in this patient. Another indirect sign is pericardial effusion or tamponade as a complication of aortic dissection, and the presence of aortic valve insufficiency at least moderate. So what's the sensitivity of each sign? A study from Europe in 2014 have shown that for direct signs, the sensitivity is 54%. That's not so good. The indirect signs were a little better, for ascending aortic dilation being the most sensitive of the indirect signs, and the others pretty far behind. Any sonographic sign of any kind has a sensitivity of 88%, which is pretty good. But when you add ADD risk score, the sensitivity and specificity significantly jump. So we have the risk score and ultrasound put together. We get the sensitivity of 96%. If you look for any sonographic sign, including indirect sign, and then specificity jump to 98% if you see direct sign, you see the flap or intramural hematoma. A study in 2019 by Nazarian, they did a sub-analysis of all the patients who got an ultrasound and found that if you got the ADD risk score, the ultrasound, and the D-dimer, you could get the overall sensitivity to 100%. The way that they did this, however, was pretty intense. Their protocol included parasternal long, parasternal short. They did subxiphoid, they did abdominal views and iliac views, and they got carotid view. This protocol took some time, and in the emergency department, this may not be something we can do effectively, quickly, and then also have high quality, sensitivity, and specificity. The protocol they came up with based on this was they did the ADD risk score, then they did the ultrasound. If the risk score was greater than 1 or direct sign present on ultrasound, go straight to CTA and get the surgeon possibly involved. If the risk score was less than or equal to 1, the ultrasound was negative. You could get a D-dimer. If the risk score was less than or equal to 1 and you had the indirect sign, you could consider either getting the D-dimer or you could get the CTA if there was no other diagnosis more likely. In summary, POCUS is useful for making a diagnosis of PE and aortic dissection, especially if a patient is too unstable for CT scan. POCUS can be specific for PE but might not be very sensitive for PE. More specific signs for PE are McConnell sign, 60-60 sign, early systolic notching, and right heart thrombus. POCUS have variable test characteristic for aortic dissection, but sensitivity and specificity are higher if you combine POCUS with ADD risk score and D-dimer. Thank you very much for your attention.